Hello, I'm Dr. Collins, and in this particular video we will explore the two main causes of female urinary incontinence, how they present and what solutions can be offered to these ladies. So, the two main causes of female urinary incontinence are urge and stress incontinence. In order to properly manage this presentation, it is vital to clinically differentiate between these two forms of incontinence. Getting a good history from the patient holds the key to the diagnosis. A woman suffering from urge incontinence will typically present with large volumes of urinary leakage, whereas a woman suffering from stress incontinence will present with small amounts of urinary leakage. Let's talk about why this happens. Urge incontinence happens due to an overactive bladder, which means that the key muscles in our bladder, the detrusor muscle, contracts far too often, resulting in a sudden urge to urinate that cannot be delayed. Women suffering from urge incontinence therefore ends up leaking large volumes of urine that is a lot harder to conceal. On the other hand, stress incontinence happens when the muscles that control urination, the most important being the pelvic floor muscles, becomes weakened. This results in involuntary leakage of small amounts of urine, a few drops, leaking when there is an additional pressure on the abdomen, for example because of laughing, coughing, sneezing, heavy lifting, exercise and so on. There is some overlap in conservative management of urge and stress incontinence, which revolves around improving the modifiable risk factors of these presentations. You can get your patients to lose weight if their BMI is high, which will reduce the pressure on their bladder and pelvic floor muscles. You can get them to reduce their caffeine and alcohol intake, both of which are diuretics and can irritate the bladder. You can also warn the patients against constipation because the buildup of hard stools in the rectum can put pressure on the bladder and surrounding muscles. It would also help greatly if your patient was advised on smoking cessation, if applicable, because smoking causes chronic cough, which increases the pressure on pelvic floor muscles, and in addition, the chemicals in cigarettes can irritate the bladder, resulting in more frequent urges to urinate. Along with conservative measures, it is important to start some form of physiotherapy exercises as the joint first-line treatment. For urge incontinence, bladder training, and for stress incontinence, pelvic floor exercises are recommended. Patients can be referred to a woman's health physiotherapist to initiate and monitor these exercises. Bladder training relies on learning techniques to increase the length of time between feeling the need to urinate and passing urine. In very simple terms, your patient will learn how to hold her wee just a little bit longer gradually. This course should run for a minimum of 6 weeks. On the other hand, pelvic floor exercises, you might have heard of them as Kegel exercises, rely on contracting these muscles and strengthening them on a day-to-day basis. A minimum of 8 muscle contractions at least 3 times a day for at least 3 months is recommended. The way I describe pelvic floor exercises to my patients is to get them to imagine themselves sitting in a bath full of jellyfish and they need to squeeze really hard to shut all orifices to stop any jellyfish getting in. It is a gruesome visualization, but it works to get them started on these exercises whilst they're waiting for a women's health physiotherapist. If conservative measures and physiotherapy do not result in acceptable levels of continence, we can step up management with some medications. For urge incontinence, we can trial oxybutynin, which helps decrease muscle spasms of the bladder and thus the frequent urge to urinate caused by these spasms. But remember that this is an anticholinergic medication, which can be quite dangerous in elderly patients, increasing their risk of falls and their anticholinergic burden. For these vulnerable patient groups, we can trial a milder oral medication called mirabegron instead, which works on the beta-3 receptors of the detrusor muscle, relaxing it and thus increasing the amount of urine the bladder can hold. Blood pressure should be monitored for this medication. For stress incontinence, we can trial duloxetine, which is a very versatile medication. As an SNRI, it is indicated for other conditions such as depression and neuropathic pain. However, in the bladder, it is thought to improve the sphincter tone during the storage phase, reducing leakage. The most common side effect of duloxetine is nausea, but it's often very well tolerated, so do consider this medication, especially if you have other treatment objectives such as improving mood. Well done, we're nearly there. A few final points. Bear in mind that in time, women can end up suffering from both of these forms of incontinence, as aging and the number of children they deliver are unmodifiable risk factors, in which case it would be called a mixed incontinence, and patients may therefore benefit from a mix and match of these management options. If the conservative measures, physiotherapy and medication management options fail, patients can be referred to secondary care to be seen by a specialist to consider further management options such as Botox injections, nerve stimulation therapies, and other surgical interventions depending on the type of incontinence. At the workup stage of the presentation, you will of course examine the patient and may also come across with organ prolapses during bimanual examination, such as cystocele or uterine prolapse, which can be treated with insertion of pessaries, for example, or in severe cases, referral for surgical correction. It is also important to assess the patient for vaginal dryness. Women with incontinence usually present around the time of menopause, and vaginal dryness can certainly contribute to the exacerbation of these symptoms, and in the majority of cases, this can easily be rectified or improved with topical estrogens. Last but not least, always keep diabetes and recurrent water infections at the back of your mind whilst you are doing the workup for this presentation, as both diabetes and UTIs can cause further urinary symptoms, which could certainly contribute to the severity of urinary incontinence. Thanks for watching. If you like this video, please subscribe to support more videos to be made. For free practice questions and more videos, you can visit the website displayed. For any video requests, please feel free to comment below. Good luck!